Well, we're just presenting our experience with these techniques. We're trying to do a minimal invasive multi-arterial technique, no touch aorta, with conventional instruments. It's at the beginning of our program in the upper middle income country in Bogotá, Colombia, as Dr. said. So this is the big mark of our treatment. Priority, this is the primary tool of treatment or one of our frequency surgeries in our practice that is frequently compared with the PCI and medical interventions. We are losing the battle because of three things: greater number of neurological problems, strokes, bleeding, infection, as well as longer recovery time. So we're trying to develop minimal invasive techniques and novel techniques with less complications and with less costs. So by routine, what we're trying to do is to do a left mini thoracotomy. It could be video assisted, or it could be directly or by direct vision of the mini thoracotomy with multi-arterial grafts. It is the lima and the radial without touching the aorta and no touch aortic technique. And it could be off or on pump. It depends on the availability of the instruments, the training, the hemodynamic condition of the patient, and the exposure. You can see a video of our own arm. It's a conventional OR that anyone will have in Latin America, and this is the operative technique. So left knee thoracotomy, the fourth or the fifth intercostal space, depending on the patient, purple handles. We use the left internal mammary, the left, the LAMA, and we use the radial artery, always doing a clinical allen test as well as radiological allen test. We perform a wide anastomosis with the radial to the middle segment of the lima. That's our operative technique. It could be, as I told you, off or on pump. When we perform it on pump, it's always hard itching. We don't use prostaglandin in any of these cohort patients. As you can see, we also have instruments that are really expensive. That's for valvular diseases, but in coronary, we use those phenocchiatrids. So those are pediatric phenocchiatrids, as everyone could have in the hospital with the small phenocchiatrids, and we use the radial artery. As you can see, those are the incisions that we're doing. When you use radial artery, it doesn't matter the age of the patient, he or she will walk the next day, and that's better. So he will recover really faster. Those are our three forms that we can perform the lima harvesting. It will be by direct vision on the incision. We can use some thoracoscopy for video assisted, as well as looking at the incision, and we can complete it thoracoscopically. As you can see, those are these. Big question is, can you do the CABG in all the targets? So the left chair, the LED, it's beautiful exposure of it, as you can see. And the question is about the obtuse marginals, the stability of one obtuse marginal, the second obtuse marginals. There's the radial artery going to be grafted on the obtuse marginals, and you use those stabilizer and the positioner, as the way you can see on the picture. This patient was a now-pump patient with heart beating. The other target we are looking is the PD, the posterior descending artery, or the PB. So with training, with complete satisfaction, you can expose the PD artery, as you can see on those pictures. This patient was an off-pump patient with heart beating technique using this disposition. Of course, it is important, the pain management, the multimodality of pain management with, of course, like 3 or 4 periods, and we use a lot of blocks, pre-incisionally, intraoperatively, and post-incisionally, as you can see with the anesthesia team. This is our timeline. When we began this, it's in the 2020, and we began doing this. On December of 2022, we have 48 patients. Last year, on September of 2023, we had 112 patients. Right now, we are about 150 patients, 160 patients. You can see there's the age of the patients, the average score, the ejection fraction, BMI. BMI is important. You can see the BMI in May of 2023. There are no fat patients, because we began this program just doing the easy cases, just to say that. And after that, we began doing more patients with bigger BMI. Those are our time of perfusion, and those are our results. Our rate of patients for bleeding is 1.17. It was just one patient because of the chest wall bleeding. Reduce less than 1%. no strokes, so that's important because PCI on the interventional cardiologist always says to us that they are better because they don't have no stroke. With this technique, you won't have any stroke. It's no percent. There are no infection, just superficial infection. 3 patients of those controllers 12, and some of them produce a granuloma, foreign body reaction. AFib is really small compared to the literature, 3.5%. Length of time of stay is similar than conventional techniques. But patient will came to your visit, we came to your office just walking, taking her jacket with no problem, with no limitations. That's really important for us. And the pain it's bigger on the first week. That was the question that they were answering and assessing in the last presentation. So first week there's a lot of pain, but after that, patient won't feel nothing and came to your office. Some example of some picture of people that with bigger body mass index. There are women with big breasts. There are normal people with body mass index normal, and our length of stay is about 8 days in total. 3.6 days in the ICU, in the intermediate ICU just 1 day, and the general ward about 3 days. So it's a total of 8 days. But you can see on the video, patient is completely happy, satisfied, and it's moving a lot. And he's fully post-operative day after we perform that surgery. He's very well fine. Obviously, we have complications. It's an example of it. We have doing conversion to conventional sternotomy. We have some lesion of the subclavian artery, so we gotta do like the trauma guys, the trauma surgeons use when there's a problem on this subclavian vein or granulomas, as you can see in the bottom left. So we believe that even with these techniques, you will have lower rate of complications, faster recovery to daily life to our patients, especially in